Hello and welcome to this Ask Me Anything live stream with endocrine surgeon Dr. Simon Holoubek. My name is Samantha Mellinger and I'm the Director of Marketing and Partnerships at the Health Professional Student Association, which publishes the Student Doctor Network forums. Our admission is simple. We help students from underserved communities increase their chances of admission to health professional school. And we do this by offering donor-supported guidance, advising, and assistance to students regardless of background or financial means. And we invite you to check out all the many donor-supported resources that we have available at studentdoctor.net. A few housekeeping items before we get started tonight. First, this live stream is being recorded, so you will be able to go back and rewatch it or forward it to a friend who was unable to attend tonight on our YouTube channel. Also, to submit a question, please enter it into the comment section of YouTube or Facebook, wherever you might be watching, and we'll pull it on the screen for Dr. Holoubek to answer. And tonight, I'm especially excited to introduce Dr. Holoubek because we actually went to high school together. So we have known each other for a long time now. So it is an honor to get to do this live stream with him. Dr. Holoubek is Assistant Professor of Surgery at the University of Wisconsin-Madison in the Division of Endocrine Surgery. His research focuses on aggressive variants of thyroid cancer and health disparities in surgery. He graduated from the University of Iowa with a bachelor's in psychology and pre-med, received his Master of Public Health in Occupational Environmental Global Health at the University of Iowa with a thesis on minority health disparities in Slovakia. He attended medical school at Des Moines University and was a general surgery resident at Franciscan Health in Chicago. And he recently completed his endocrine surgery fellowship at the Medical College of Georgia at Augusta University. And we are so excited to have him with us tonight to answer any questions that you have. So before we jump into some specific questions, why don't you share just a little bit more about yourself and any initial thoughts you'd like to share?
Well, thank you so much for the lovely introduction. Yes, it is true that we went to high school together a long time ago.
Yes.
So it seems. A few different things. So this is fun. A couple things that are important to me are health inequalities and having better representation in medicine because not all your doctors should look just like me. Okay, and even though I am a white male, I like to champion people who aren't white males because many of the patients that I take care of and have been taken care of for the last many years don't look exactly like me. And I think, there's a lot of different reasons for why these disparities in health as well as in health providers exist. And so I think, the first thing to do is always to talk about them and then move forward with trying to figure out ways to address them. Some of the things that I like to do clinically are pretty focused, actually. So even though I am a general surgeon and do some general surgery, which basically means adult abdominal surgery, the majority of my practice is focused on the thyroid, parathyroid, and adrenal disease. It's a very small specialty. Only about 25 of us come out of fellowship a year, so it's a tiny specialty that not everyone has heard of. It's particularly academically focused, so you'll find many of us in larger university settings. But it's a really rewarding career where many patients, do very well. The surgery is very delicate. We have inspiring colleagues. A lot of people are doing research. My research, as Samantha was mentioning, focuses on aggressive thyroid cancers and how to best treat those cancers. In the past, a lot of these cancers have been taken care of with aggressive surgeries. And for us, it usually if you just think of it as more surgery, so whether or not you need to take half the thyroid, the entire thyroid, and if you stop there, or if you continue on and take lymph nodes, and more is not always better, is what we found out over time. That's just kind of a general trend in endocrine surgery. As well as I like to look at health inequalities. most recently, it's been looking at health inequalities with regard to adrenal disease. And I really just started my career, so I've been doing a lot of things over the last several years, as noted in the introduction. But I just started my career fresh out of residency and fellowship, and just started up at the University of Wisconsin-Madison, and looking forward to answering questions for those who are 10, 12 years behind me.
Yeah, so just one more quick reminder, if you have questions, please insert them into the chat and we will pull them on the screen to be answered. At any point in the conversation, feel free to put those in there and we will pull it on the screen as appropriate. So let's get started. We're going to go kind of way back to the beginning. When did you decide to be a physician and why?
Yeah, a good question. So I think you get a variety of answers, and everyone talks about that, especially as they're getting into medical school, but it's something that still comes up. Someone asked that question today of like, why a doctor, why a surgeon, why an endocrine surgeon? I think a lot of it comes down to mentors. So, in college, I went in with the idea that maybe I wanted to do something in health sciences. Physician was somewhere on the top of the list, but I know a lot of people come in pre-med, and a lot of people leave not pre-med. And there's a lot of reasons for that. And I think that's okay, because, being a doctor is one of those professions where, you can be like 15 or 16 and you ace a chemistry test in high school, and then you're convinced that you should be a doctor. And then as you get a little bit closer to it, you start realizing like, oh, that's like a lot of work. It's a lot of years. It's a lot of money to go to medical school, I think, which is an important consideration. There's some issues when it comes to men versus women and the amount of encouragement they get, especially if they're interested in having a family. And so you'll find that oftentimes, a male will be mentored differently than a female, even if they have the same grades, even if they have the same background, even if they have the same goals. So I think that's kind of multifactorial. That being said, when I was 18, I was looking to shadow a physician, and I was really fortunate to put my name in to shadow a craniofacial plastic surgeon at the University of Iowa, who was a fantastic mentor. His name was John Kennedy, and he was the former president of the American Society of Plastic Surgery. So, the short kind of version of this is he was a bigwig. He was very highly respected, but he was also one of the friendliest surgeons I've ever met. I still talk to him from time to time. And I got to see the way that he took care of patients, which for him was mostly small kids and their worried parents when they saw that their kids were born with a facial abnormality. And even though that wasn't my path, to become a craniofacial plastic surgeon, I saw the way he took care of patients, and I saw how inspiring it was that his science background led him to a career where he could take care of, frightened patients, frightened families. And although it wasn't always something like cancer, there's all these other things that can have either social ramifications or lifestyle ramifications, and he was able to hold their hand through the entire process, take care of them, and see them on the other side. And he frequently had patients who would come back years later, and you'd see the excellent results of the surgery. You'd see how thankful they were. You'd see a hug from a 16-year-old, and you couldn't, barely tell that they had had many, countless surgeries over the years, correcting both cleft lip, palate, dental, nasal deformities. And that definitely inspired me, not only to become a physician with the science training I was, undergoing at that time, but to look into something like surgery and to see if I could, be that kind of surgeon. for medical students who are out there, they may know that there's this stereotype of the mean surgeon, and for pre-meds out there, there's sometimes a stereotype of the just technically excellent surgeon, and they're always curing cancer or something like that. But I would say that this mentor didn't necessarily fit into either of those roles. He was curing all kinds of other things other than just curing cancer, which is a good line on a TV show or something like that. But he was also really gentle and really caring. And you could tell he really cared about his patients, and he really cared about his mentorship role with me. And that's been something that always stuck with me. And whenever possible, I've tried to do similar things for people younger than me, or people who aren't as far along on this process, in order to help guide them through the process and realize that there's a lot of different careers in medicine, ranging from psychiatry, family medicine, pediatrics, all the way to something really specialized in technical, like cardiac surgery or other surgical subspecialties. As well as there's a lot of different personalities in medicine, and there are a lot of different types of providers, a lot of different types of physicians, and that does get incrementally more heterogeneous every year. That more and more medical schools are focusing on trying to have a physician population, or a medical school class that better represents the United States.
Absolutely. So we've got a question here from the audience. How does the DO background impact, or how has it impacted your outlook on specialty choice, challenges in general surgery residency programs, and specifically fellowship, given such a small niche? I know this is something we talked about before we went live.
Yeah.
So this is a perfect question.
Yeah, perfect. I was gonna address this in case no one asked, but I think it's one of the obvious questions, especially for people who have contemplated going to an osteopathic school. I will say it didn't help. But there are more DOs who are going into subspecialty care, although, with the recent ACGME merger, I think there's some questions about what that will look like in the long term. I can't speak to that a lot. I did go to a historically osteopathic general surgery residency that did merge during my residency. So that was, something where I got to see the changes, and I thought a lot of those changes were for the better. But I will say that it matters somewhat who the candidate is. Like, not every DO is going to have great opportunities coming out of a DO program. But that's also true of people at an MD program. So it kind of depends on which school you go to, how you do in that school. And it still comes down to a lot of your personal interest. And, if you really want to be a surgeon and you have the, the grades, the research background in order to do it, and then you go to a general surgery program that allows you to, really flourish and not only develop your clinical skills, but also take part in meaningful research projects. I think it is possible to do almost anything. And I will say that, 2 people from my class of 3 in residency, became endocrine surgeons. So I think that, that says something about my residency program, and it just tells you that, just because there aren't a lot of DO, subspecialty surgeons out there, doesn't mean it can't happen. And so, I think you just have to ask, like, who am I going to be when I'm in medical school? Am I going to focus on something more surgically oriented. And, so overall, I'd say it is possible. I don't think I'm, the biggest exception. I don't think that there's anything particularly special about me, but I will say that I took research blocks during medical school. I networked really aggressively in both medical school and residency. I did quite a bit of research in residency as well. I wasn't able to take research years, so I just did it, during nights and weekends, and did have some time built into my schedule based on a program director that was championing my research interests, as well as allowing me to go to conferences that I was presenting at. But I think that the issue as to why it's harder for a DO versus your average DO versus your average MD to be a kind of a surgical subspecialist is that there's going to be less focus on research and subspecialties during medical school. So, there's bottleneck kind of number one. During residency, you're probably not going to have a great research network or a lot of subspecialty surgeons offering mentorship in residency. And then there's oftentimes going to be a little less initiative to do quality research during residency. And when you kind of add all those things up, you find that there's not a lot of DOs applying to some of those small fellowships.
Well, and I just love that you talk about networking and the importance of that. That's one of the big pieces of advice a lot of our experts within our confidential consult section of our site often gives, pre-meds, medical students interested in all of these things. You've got to network, you've got to ask these, and put yourself out there. So I love that you talked about that. And a great follow-up question that we have is, what advice do you have for a DO general surgery applicant who has that below average step 1 score?
Mm-hmm. Yeah. It's been a while since I applied and matched, but I will say apply to more places. Definitely try to put yourself out there. I will say, sending emails is relatively low yield, but sending an email to say, hey, I'm really interested in your program. I will say that's something I found to be helpful over the course of networking and trying to stand out is sending a headshot and a well-groomed CV every time you send an email. So you don't just say an email saying, hey, I think your program's the best, and then copy paste and send it to the other 100 programs, but rather trying to send something to maybe 10 or 20 programs and, use their first, or use their name, use a few features of the program, and then add your CV and a headshot. And if you can go there for a day, or if you can, possibly have someone make a phone call for you, I think that's all helpful.
Absolutely. So another question we've received, what can you do during medical school to increase your chances to get into a top choice residency?
Other than all the typical things people talk about, get good grades, get good scores, get good letters, something that isn't really popular to say, but I know people have done it, is they take a year off to do research during medical school. Seems really aggressive. A lot of people do that kind of thing in residency. They get paid for it. It seems to be a good time to be able to really contribute and do high quality research. If you're like a third year resident and you're already kind of plugged in with mentors, that can be useful. But I do know a few people who did that during medical school. And they applied for jobs and they got research jobs, got paid $40,000 or $50,000 for the year, and they put out 3 or 4 or 5 papers. It definitely makes you stand out because it's unusual. I think it's a little risky to give up a year to do that, but you have to realize if you take an entire year to do research in medical school, you have to have something to show for it. I will say that's kind of true in residency, but some people are just forced into it. And so you'll see at some programs, let's say everyone has to take 1 year off, you'll find that some people, either they or a spouse has a kid that year, or, they work on other things in life and they maybe publish one paper or something like that. But during medical school, if you're taking a year off, you need to have something to show for it.
So what is your schedule like these days?
Yeah, so a good question for an endocrine surgeon, because an endocrine surgery schedule is better than most schedules. So the current schedule, because I'm new to attending life, I'll kind of give you the broad outline, although mine will be changing a little bit, and then my outline of my schedule last year, and then maybe a little bit of my schedule during general surgery, which was very different. So now I take call about once a week, a little bit less than once a week, for a primary 24-hour call with level 2 trauma. And then I also take one backup call about once a week. So that ends up meaning about every 4 days or so, I'm either on call or on backup call for 24 hours at a time. When I'm not on call, my basic schedule is operate Monday, Tuesday, Wednesday, full day office Thursday, and then research on Friday. And if I'm not on call for the weekend, then I don't have weekend responsibilities unless I have patients in the hospital, in which case I'd arrange either me or the on-call person would round on them. Last year, I would say, is a little more typical, and I was mostly operating Tuesday, Wednesday, and then variably on Friday. And that was based on fellowship schedule, and then in the office, usually on Monday and Thursday. And then Thursday was an independent VA clinic or operating room experience for me as a fellow. And then the rest of the time, meaning Monday, Tuesday, Wednesday, and Friday, I was with either my fellowship director or my associate fellowship director. And I had no call responsibilities, but if there were patients in the hospital, I'd round on them. And then in general surgery residency, the typical schedule is about 80 hours a week, and usually having about 4 to 6 days off a month, and usually doing about 5 24-hour calls. But when you're a junior resident, it'll be as much as every third day. So I've taken call as much as 11 times in a month, which is quite a bit. And that was at a level 1 trauma center in Chicago. And so that was really busy. And so, it's definitely different to be an endocrine surgeon versus a junior general surgery resident. And so I think that's just important to have in perspective, because lifestyle can change over time depending on what you do for fellowship, what kind of hospital you're at, what kind of group you're at. Is it a large group? Is it a 2-person group? So those are all the different things that people need to consider as they go through the process, because I know a lot of people are very frustrated when they're a second-year resident working 80 plus hours a week on call every third day. But if your end goal is to be the same, then maybe you need to think about that. Or if your end goal is to be a breast surgeon working more like 40 to 50 hours a week on call, maybe all the time, but on call for breast means a few phone calls a week about pain meds and very little else. That can be worth thinking about. Just like, what do you want out of a lifestyle? What do you want out of a career? Because I think it's important to balance both what you and your family can endure schedule-wise with what do you want to do? Like, who do you want to take care of? What kind of skill set do you want to have, and do you want to be using on a regular basis? Because if you really want to be a heart surgeon, you're not going to be satisfied doing breast surgery Monday through Friday. And so I think that that's something that people have to think about once they become a surgery resident. What do you want at the end of the day, and who do you want to be taking care of?
So a good follow-up question to this, because this is, a lot of questions we get, especially speaking with specific specialties or subspecialties, is, do you have enough time to spend with your family? What does that look like for you?
Yeah. I think, I guess the short answer is yes. I will say that it helps that my wife and I don't have kids yet, so that's a different, hurdle that everyone decides to go through or not go through over time. But yes, in general, I do. That was at least a part of, how I chose my program, how I chose my fellowship, was having that in mind at least. But I will say that wasn't the primary focus of my specialty. But I think it's important along the way to at least, think about all the things you want out of life when you're choosing your career, and whether or not that means becoming a physician versus a dentist versus, a financial advisor, or, becoming a family medicine doctor versus a surgeon, or, becoming a heart surgeon, versus a general surgeon. All those things are a little bit different, and there's no right or wrong answer. But in general, endocrine surgery is one of the more, I would say, light to moderate schedules within the surgery world. So it's still busy, it's still stressful, but it allows me to have enough time.
And so another follow-up to that, how do you balance your work, your hobbies outside of work? How do you find that balance? And how has that changed since maybe general surgery to now practicing?
Yeah, I will say sometimes it's just making a list and putting something fun on that list. Like, I will go for a run today. I will hang out with friends tomorrow, and trying to just force at least, one fun activity in there. It's definitely gotten better over the last couple of years. But I think it helps to either have someone along for the ride with you who's going to help force you into doing something other than just medicine. But you really have to understand that you can give time to medicine all day and all night, and there's never going to be a reason to stop studying or stop reading or stop doing research. I mean, if I wanted to, I could do research, all night until tomorrow morning at 7 a.m. Like, there's stuff to do. There's stuff on my plate. Like, if I really wanted to do that, sure, I could read 1,000-page book, next week if I wanted to. So instead, what I do is I say, I'm going to read this many pages a night, or I'm going to, work on 3 PowerPoint slides of a research presentation. And you have to kind of just budget your time, budget it towards, surgery, budget it towards, the research I'm doing, budget it towards my family, budget it towards just myself if I want to, go for a run or ride a bike or something like that. But it is hard because you're not going through life bored trying to figure out stuff to do. You're rather, busy most of the time. My mind is oftentimes thinking about something clinical, or thinking about something, a research idea or a meeting I have tomorrow or something like that. So you definitely have to prioritize having something else too, or else you'll never get to it. And along the way, you do meet those people where they've not thought about anything other than their specialty for the last few years, and you ask them about an interest, and they said, "Oh, I haven't watched TV in 10 years," or like you like point out something on the news or like something on Netflix everyone else is watching, and they give you the stare, and they're like, I haven't watched that, like I've never heard of The Simpsons, or I've never heard of, like something, and you're like, but that's been around for decades. Like, how have you missed like, like you've never seen one episode of this, or like, did you know that, like Elon Musk, was doing stuff a couple weeks ago and talking a lot, like, and they're like, I have no clue who this is. Like, you have to pay attention to the news, and you have to kind of be engaged in the world too. And I think that's part of like trying to relate to patients too. Like it helps if you know what the weather is, and it helps if you know what's going on in the community, or else, what you may be gaining in, one aspect, you're losing in another aspect by being an unrelatable human. And that ends up being an important part of being a physician as well.
Mm-hmm. Great. So some more questions. In addition to the organs that you specialize in, what are your thoughts on the pancreas and its relationship to type 2 DM and its relevance to health and inequities?
Okay. I will say that diabetes falls completely outside the realm of endocrine surgery. However, some people do operate on the pancreas who are endocrine surgeons, although my program didn't do that, and most don't do that. I do think that type 2 diabetes does have relevance when it comes to health inequalities. Again, kind of falls outside of what I do on a day-to-day basis, but I think in the larger picture, I think you can look at you can look at obesity, you can look at access to care, and outcomes for people with diabetes, and the follow-up care they get. And I do think that there's research to suggest that health inequalities exist across the board pretty much, and that also pertains to people who have type 2 diabetes. And so I guess it falls a little bit outside of my wheelhouse, but I do think that it's one of many important factors in health inequalities.
Great. How would you characterize the current job market as it pertains to general surgery fellowship pathways? This is a big question we get for just about every one of these questions, is what does the job market look like?
Yeah. For general surgery, it's strong and is pretty much always strong. COVID definitely had some hiring freezes at some hospitals. But if you didn't do a fellowship, it was pretty much always strong, because it's such a broad skill set that someone will find something for you to do, and call is pretty stressful, and there's always someone either retiring, or always someone who says, if we just had one more general surgeon in the call pool, that would help. Fellowship specifically narrows your job market quite a bit. If you're an endocrine surgeon and you're willing to go anywhere and do mostly general surgery, and then kind of in the back of your pocket, you can say, I'm an endocrine surgeon, so if there's a thyroid, I'm going to do that and not refer it out to someone else. That's still a pretty healthy job market. Once you decide, though, that you want to be a very focused endocrine surgeon who may take some general call, or possibly not even take general call, you start narrowing down your search to places that have a long list of thyroids that people aren't fighting, over when it comes to kind of like turf wars within surgery. So even though there were about 25 plus or minus a few fellows this year, I will say not everyone has found a job, even though we graduated like 3 months ago, which is abnormal. If you're coming out of general surgery, many people have jobs lined up 6 months in advance, some people years in advance. And out of the people who did find jobs, I will say only about half of them are practicing, greater than 50% endocrine surgery. And so many of the jobs went to people who were happy to do, 50% or more general surgery. And, oh, by the way, I also like to do some endocrine, versus, my situation to where I'm, planning on doing the vast majority endocrine and then only general surgery when on call, or if, other situations may exist, like, there's a patient who had their thyroid out last year and they came back to my office and they now have a hernia or something like that. That situation can exist. But I'm in that kind of small niche category where the job market can be quite difficult. Colorectal, I will say, is generally better. Many colorectal surgeons will do general surgery and they'll just try to get, more colon cancer referrals than their colleagues in the general surgery group. So I would say, in general, their job market is stronger than the endocrine job market. But I guess if you specifically wanted to do like minimally invasive colorectal all the time at a major university, it would still be a pretty tight job market. But again, not quite as tight as an endocrine surgery job market. And then hepatobiliary, probably somewhere in between. I don't have a lot of HPB trained friends, but the ones I do have, they have jobs. And I'll say that the person that comes to mind was pretty flexible as to what location they'd work in, and they are doing some general surgery. I'll say probably closer to 50% general surgery. So again, if you wanted to do HPB and you only wanted to do HPB, it would be probably a little bit tricky. But again, somewhere in between endocrine and colorectal surgery as far as how good the job market is, with the endocrine job market being the smallest. So even though there's about 25 graduates, I will say there's, only maybe 15 endocrine surgery jobs for those 25 graduates, and the other 10 will decide to do general surgery jobs. And a few people end up doing another fellowship. So a lot of people, if they're going to do another fellowship, will consider something like minimally invasive surgery or breast. Those are the popular ones where they basically combine another 1-year fellowship on top of an endocrine surgery fellowship, which is usually 1, but sometimes 2 years.
Great. So this viewer would like to know how they can get involved in research with you.
So I'm not quite ready to be taking anyone for research. That actually came up recently. And there is a really nice program at University of Wisconsin-Madison that has basically tries to focus people from underserved backgrounds or more diverse backgrounds and tried to do research with mentors at the University of Wisconsin. So it's nice to see some of those pathways exist that kind of get back to what we started this discussing. But getting involved in research with me remotely would be really hard at this time. And so I don't think I'd be able to offer you or anyone else here exactly what you'd be looking for. Although I hope that changes over time. And I will say that one of the learning curves going from a resident to fellow to attending is, not only doing research independently, but being able to guide someone on their own projects. And I feel like, I only recently over the last couple of years moved from, having mentors guide me through projects to me doing them independently. And I'm still a little while off from being able to, I think, confidently and successfully guide someone below me through a really meaningful project, especially remotely. But I do think that over the last 18 months of the pandemic, I think it's a great opportunity for people to reach out to mentors who may want to do research with people, over Zoom or different types of media like that. And I think it's worth, trying to find people and like I had mentioned earlier, send out your CV, send out a headshot, and send out maybe a personal statement, something that says what you're interested in, and how you may be able to contribute to a project. Kind of a like something to add to that is many DOs, including some people in my general surgery program, would be interested in research. However, they were having a more difficult time than me in networking to find quality mentors because they didn't have prior research experience, which I think is always something that's difficult, when you're looking for a job, in anything, and you're turned down because you don't have the right experience. And so you're like, well, how can you give me that first experience? Kind of just like what we're talking about now, someone saying they're interested in research. And I said, I'm not quite ready to take on someone, especially, during a pandemic. But I think it's always important, if you want to have research be a meaningful part of your career, to start, with the sort of minimum wage equivalent. So during undergrad, I was doing data input. And then, during medical school, I was doing, multiple research blocks in order to do something that was mostly data input. But then, I started writing some abstracts too. And then in residency, I was went all the way to, writing manuscripts, presenting at conferences nationally and internationally, and then to recently, getting hired for a job that has a research component to it. But that trajectory was something that was slowly built over the course of 12 plus years. And I spent a lot of time, typing in Excel documents and, in databases, kind of mindlessly plugging in, yeses and nos for years before I was, ready to write my first manuscript. And, definitely before I was, ready to speak in front of an audience of people. So I would encourage, this person, as well as other people, to start on something if they haven't already, and try not to be frustrated if they don't have the right experience, because that's just built over time.
Yes, I was going to ask you, how do students get involved in research? But you did a wonderful job answering that.
Okay, I see.
Regardless, so thank you.
Yeah, I guess be open to not publishing, not being on the publication, and just doing small tasks. And, I definitely had friends who joined a research team when they're 18 years old and they were on a publication like 10 days later. And I applaud them for finding the right research team that was that, that proliferative. However, I did research on and off for probably 5 years before I ever, found my way onto a publication. And then over time, I wasn't finding my way onto publications, but rather writing those publications and being first author. So I think I didn't have the quickest, sort of progression when it comes to research, but I think I had one that's realistic, that many people, if they're interested in something academic, that they can do. Basically, it's like the idea of, like you scrub the floors at the place, and then you start, making the food at the place, and one day you own the place. Like, not everyone gets to do that, but it's definitely easier to do that model than to just own the place on the first day. And I'm, quite impressed by people who are, publishing as a first author in medical school and stuff like that. Like, I wasn't ready for that, and I didn't have that background. And oftentimes when you see those people who are doing that, they usually have some mentors who are really championing them, or they've been, working towards this for several years before that, and you didn't even know that. I knew someone who took, some time off after undergrad and just went to a research lab. And so, as you can imagine, by the time he was in medical school, he was already, publishing his first author, because he had a pretty robust experience in his early 20s already, and was ready to do that once he was in medical school.
Wow. Okay. How does your osteopathic-specific training play a role in your surgical or other medical roles?
Mm-hmm. I hate to disappoint my medical school professors, but not very much. I had this conversation with someone from my residency program recently, who's an MD, trained 40 plus years ago, and we were talking about the difference between being an MD and a DO. And for some things, I think that there can be a difference, and sometimes that's a meaningful difference. It's really hard to have a meaningful difference between a DO and an MD when it comes to surgical care. Because if someone has appendicitis, you do an appendectomy. There isn't a question about, like, I'm going to do something specific as an osteopathic physician. And I will say, I'm proud of my DO roots. However, I don't think DOs have, the monopoly on anything. So when it comes to, patient-centered care, or being nice, or being holistic, or the idea of treating the whole person, or putting your hands on a person, these are phrases that I often heard in medical school. But working alongside MDs who are also thinking about all these things at the same time, I can't say that there's anything specific about being a DO that allows me to care for someone differently. Again, that's as an endocrine surgeon. That might be different if you're in a more primary care focused specialty. But I think at the end of the day, it's virtually all the same books. More and more so, it's becoming the exact same tests. At the end of the day, it's the same patients too. So, if someone comes to you with a fever and a cough, you don't treat them as a DO versus an MD. You have to work them up and decide what their ailment is, and and you kind of go from there. And in 2021, it's probably COVID. So just let me know.
Yeah. Yes.
Yeah.
All right. Did you ever consider anesthesiology?
I think I can imagine this question is because I'm a surgeon, so
Yes.
There's a lot of people who are on the fence. Do I become a surgeon or an anesthesiologist? Yes, I did. That was something that was in my mind, because I decided I wanted to be in the operating room. I was pretty sure I wanted to be a surgeon. I wasn't sure that I needed to be a surgeon, at least for a little while. And then I had an anesthesia rotation, which not everyone gets to do. And when it comes back to mentorship, I will say, the mentorship experience I had in anesthesiology was not as strong as my mentorship experience in surgery. That being said, I intubate people. I feel very comfortable with intubation, and I like to at least assist, if not, intubate people myself with my patients, because typically we start with the table backwards, if you've ever been in the operating room when I'm operating. And so it's easier to operate if you have everything kind of flipped around for thyroid surgery. So not everyone is up by the anesthesia machine. And that can make some anesthesiologists a little nervous to have just the feet next to them. And so we help them secure the tube, and we help them intubate the patient. But at the end of the day, I found myself not very interested in anything other than the initial intubation. And you'll find yourself, if you're in medical school, you'll either be the surgeon who likes being up at the head of the bed, or the surgeon who's kind of looking at the anesthesiologist, and the same way around if you're on an anesthesia rotation. You're either like fascinated by the tube and the gases and the meds and the pharmacology of it, or you're just going to be looking at the surgery the whole time. And I found myself, very engaged when I was on my surgery rotation, and I found myself very engaged in surgery when I was on my anesthesia rotation. And I think that kind of helps someone figure it out. But if you're not sure and you're in medical school, I advise people to definitely do both rotations as soon as they can in order to figure that out. I will say they're very, very different. And so if you want to be a surgeon, being an anesthesiologist isn't a close second. It's completely different. So I would highly advise someone, if they really want to be a surgeon but don't think it's in the cards for them, I wouldn't tell them to be an anesthesiologist. I'd tell them to be whatever else they want to do, because again, being an anesthesiologist isn't like being a surgeon. It's pretty different.
Now, this is a great question, because in general surgery residency, you mentioned working, 80 hours a week. So how far from the hospital do you think one could reasonably live during that time?
So because I lived in Chicago and we went to multiple hospitals, I lived really far away. So when I started residency, we had a hospital that was 55 minutes away. And when I started, that was the most common hospital I was going to. We merged with another hospital, and that had already started to take place by the time I had chosen a place to live, which was only 45 minutes away. But I still drove 45 minutes, every morning for the majority of residency. And then in the evening, when I'd be driving home, I'd be hitting rush hour traffic, and it would frequently be more than 1 hour. And that being said, I took in-house calls, so I wasn't at home coming back to the hospital, and many general surgery programs will be set up that way. So, I mean, it doesn't really matter how far you are from the hospital if you're taking in-house calls. So for people who don't know that distinction, meaning when I was on call in general surgery residency, I was sitting in the hospital for 24 plus hours at a time. I wasn't going home, to take a shower and then run back to the hospital. And I only took home call very selectively in my program. And I knew that, going in when I chose to live where I wanted to live. It's different if you're taking home call, in which case I would tell you probably 10, 15 minutes, or figure out what the culture is with, what the expectation is at your hospital. Depends a little bit on who else is in the hospital. Maybe you're a chief who has to go in, but you have first or second year that is in-house. So that's a consideration. And, are you a level 1 trauma center, level 2 trauma center? What are the logistics of that? And what's the traffic in the city that you live in? And winter is a thing in the Midwest. So, your commute might be 10 minutes today, but it might be 30 minutes tomorrow if it's snowing. And then, typically when you're an attending, you're not going to be taking in-house call. And typically response times are going to be less than 30 minutes. I currently live about 10 minutes from the hospital. So, that's a little bit different for me.
Yeah. So this is a great question to kind of wrap up this evening. Did you start out focused on becoming an osteopathic physician versus allopathic? And how is that and the other whole person training influenced your trajectory?
All right. This is, again, I don't want to disappoint any of my professors, but I never really looked at it like I'm a DO instead of an MD. I entered medical school going to the DO program, that was 25 minutes away from home, that had trained several people in my community, including my own family physician. And I didn't necessarily look at myself as a different kind of physician. I looked at myself as, I'm a doctor, and I'm, in medical school to become a doctor. And then I was, a medical student trying to become a surgeon. And then I was a surgeon just trying to be a good surgeon. And then I was a surgeon trying to focus on being an endocrine surgeon. So I didn't really look at it as I'm an osteopathic physician focusing on osteopathic principles or focusing on manual medicine. I mean, these are things I learned along the way, and I, try to embrace as much of the teachings, that were in front of me at the time. But I think, I would say from my perspective, there's not as much wiggle room in my mind as some people make it out to be. I don't see it as like, oh, I'm going to treat someone completely different because I'm a DO versus an MD. Like if I was an MD, I was going to give them a pill, but since I'm a DO, I'm going to treat their whole person and I'm going to do something very different. I still look at medicine as relatively black and white. Like there's right answers and wrong answers, and there's a lot of gray area in between. But I have a lot of friends who are DOs and a lot of friends who are MDs, and they call me about difficult patients and I call them about difficult patients, and we don't go through things in a DO kind of way or an MD kind of way. We talk about a patient who has thyroid cancer and how we're going to safely take the thyroid out and what we're going to do afterwards. Honestly, if we were talking about a heart attack or a stroke or high blood pressure, it would be the same thing. We're just talking about, who's this patient, what's going on with them, how do we best treat them? And yes, we are thinking about the whole patient. We're thinking about whether or not they can afford the medicine, whether or not they're in prison, whether or not they're recently divorced or someone died in their family. And that is a consideration. And I think that was focused on in my DO program. But I also have friends who are MDs, and I know that their schools also have taken an increasingly focused approach on those other aspects of a patient's life that can be contributing, to their overall health picture. So, I am a proud DO, but I will also say that being a DO doesn't really influence the way I treat patients. At least not knowingly. Maybe there's some subtle things, but for the most part, I think, MDs and DOs are pretty similar.
So I like to end these with kind of one last question. In your position now, knowing all that you do, what is one piece of advice you would say back to yourself when you started?
Have more fun, be a little more lighthearted, maybe. I'm not quite sure, but I guess I'm glad that I've always been thinking about the next step. And so I'm thankful that when I was in undergrad, I was thinking about how to get into medical school and how to locate good mentors. And then, same for the next step and same for the next step. For the most part, I'm where I wanted to be. And so I think that's really exciting. But, making sure that you live life at the same time, because I think it's very easy for people in any career, but I would say specifically in something like surgery, to have that tunnel vision and you wake up 10 or 15 years later and you start regretting that you haven't done other things. And so I've always taken that approach of make sure you're doing other things in life other than just medicine, because like I said earlier, there's always more that you can give medicine. And it is important to take the responsibility very seriously, but it's also important to make sure that you're living your life at the same time. So, make sure that while you're honoring the importance of medicine, you're also not so tunnel vision that you're not having fun in your life along the way, and that you're not making meaningful relationships, because at the end of the day, your patients will notice that. Not every patient, but it comes across whether or not you're a relatable person, and I think that at times can be just as important as all the other things you're doing in order to be a good physician.
Well, great. Well, thank you so much for your time tonight. I know this was a great conversation. We had a lot of great questions. If we were not able to answer your specific question, Dr. Holoubek was gracious enough to share his Twitter handle with us. So I believe that was shared out in the chat during tonight's live stream. So feel free to ask him questions, extend those conversations there, as well as if you are watching this post, the live stream, feel free to ask questions within the chat feature as well, and we will try to respond and provide whatever answers or information that you are asking. So thank you again for attending tonight's Ask Me Anything webinar. If you joined us late again, this will be available for viewing on our YouTube channel after tonight. And again, we would like to extend our gratitude to Dr. Holoubek for taking the time to answer your questions this evening. And just lastly, we'd like to remind you that we have many donor-supported tools and resources available at studentdoctor.net to help you with your journey to becoming a healthcare professional, and we invite you to check them out. Thank you so much and have a great evening.
Thank you.